All right, this is the abdomen pelvis portion. This is going to be one of the most common imaging procedures you perform. The CT abdomen pelvis and the CT head without contrast is by far, it's like the chest x-ray of radiography. Okay, you're just going to do it. The indications for these procedures are basically any kind of abdominal pain. And if you work on an evening or a night or close with the ER and less with the outpatients, this is going to be the bulk of what you do. Some of the common indications are going to be right lower quadrant pain, looking for appendicitis, epigastric pain, maybe pancreatitis, constipation, small bowel obstruction, fever. Sometimes you just do it because they have a fever and some slight abdominal pain. It covers a wide variety of symptomology that will be an indication for a CT abdomen pelvis. Now, when we talk about scanning the abdomen pelvis, there's really like three categories that are commonly looked at. Okay, the most common and the standard is just the CT abdomen pelvis with contrast. All right, now that's we'll go over the protocol for that. It's really straightforward. There's not a lot to it. You may not even have to bolus track. Some facilities don't. Then there's the renal stone study, which is basically just an abdomen pelvis without contrast, done prone, and you may shorten your scan range to just above the kidneys instead of making sure you include the entire liver. So those are kind of the really common ones. The other things you might get into is like a CT angiogram for the abdominal aorta, AAA study, an abdominal aortic aneurysm, and that's a CTA of the abdomen from basically the lung bases all the way through past the bifurcation of the common iliacs and whatnot. Okay, so and then finally, one thing you really need to know about, and if you see this more on outpatients, if you work with an oncologist or at a facility that does cancer treatments, you will see these often. And these are like biphase or triphase studies, okay? Now, I don't know that I have any copies or any available scans right now of that. So I'll just talk to you a little bit about it right now. It's a CT of the abdomen pelvis, and those are usually with and without contrast. And the reason is say someone has a primary liver tumor or even metastatic liver disease. What you'll do is you'll scan it without contrast, then you'll scan an arterial phase, and then a delayed phase. And that may be like a portal venous phase, and potentially with the liver, you'll do a delayed as well. Beyond that, up to 10 minutes. So those are multiple phases or triphase or whatever terminology they want to use for that. Also for the kidneys, like a kidney mass, you may do a triphase study, or a pancreas, those kind of things. Adrenal glands, you'll do that for that. And it's just the same structure, the timing just may vary. There'll be a without, a with, or a without, an arterial, and then a delayed with kind of scan for that. All right, so those are the main ones. Again, to recap, the abdomen pelvis with contrast, the renal colic study, very similar. Then the CT angiograms of the abdomen. As a note to that, the general aortic aneurysm is one, but you also may do a CTA of the renal arteries as well. Those are just more specific. And then like a triphase of any of these particular organ groups, pancreas, adrenal glands, kidneys, liver, whatever, to see the various phases of enhancements that those organ systems may go through. Okay, that's kind of a quick rundown of abdomen pelvis imaging. I'm gonna try to keep this short today. We'll go through the abdomen protocol, and then yeah, we'll do that. All right, guys, let's take a look at this protocol. We've talked about protocols in the past, so this is going to be very familiar. But look here on John Doe to the left, we have his scanogram, his topogram, really whatever you want to call it, depending on the vendor. Typically, I showed you that first video showed you the centering for this, but it's basically at the nipple line, almost like you would for the top of your light field at upright abdomen, right, to include the diaphragm, because we know that the diaphragm sits right above the liver on the patient's right side. So we need that on our scout so we can set up this scanning range here, this pink box, above that. We don't want to go too far above because then we're increasing the patient's dose beyond the scope of this particular examination. And then we want to go here. If you notice the how low it went here, we typically want to include all the way through the rectum. If they were to have like a potential inguinal hernia, then we would want to go lower. If for some reason they had something, an issue with the testicle, sometimes we scan all the way through that too. We want to catch that if we can in the typical contrast enhancement phase, which is portal venous for this. All right, so we do our topogram. We can see the order of the exam here. We'll do our scalp. Then we will set up our pre-monitoring. Our pre-monitoring slice, I typically set it in the liver, so about here where this line is. And then if you look over here, we set our bolus tracker in the descending aorta. This is a good patient to make a note of because a lot of patients have coronary vascular or atherosclerotic vascular disease, right? It was that ASVD, I think is how you'll see it on the reports. But they have all of these calcifications of these plaques within their arteries, especially the aorta. And so what you'll find is if you place that bolus tracker over that, it's going to trigger because it's going to measure that. You see it's as white as bone. So be careful, be mindful. They had a nice center circle here that allowed them to get within the actual lumen of the aorta and not the calcified portion. But be mindful, because if a patient is breathing heavy, their abdomen will shift during your monitoring once you've started your bolus tracking, and you can get in trouble and trigger early, and then you'll be a little too early on the phase. All right, so we do our scout, we set up our pre-monitoring, we move the scanner to the monitoring phase. We can see that they've triggered the monitoring. As far as our injections go with this one, look here, we've got, we're going at 3 cc's a second. That's our typical flow rate for an abdomen pelvis. It's not a lot of pressure. You can inject through a 20. You could go through a 22 in the AC. It's not common, but it's doable. And on smaller patients, it doesn't hurt if you have to cut down the flow rate to like 2.5, maybe 2 if you're desperate, okay? Because some contrast in some cases is better than none. But typically it's 3 cc's a second. We use 100 or 95 milliliters of the Omnipake 300 for this. And once we've done the test injection, then we turn around and we start our injection here, and then this button would be flashing, we'd start our monitoring. Okay, so then what we get are these monitoring slices. It counts down, I think, if we look here, 15 seconds. I don't know if you can see that. It's gonna count down 15 seconds here before it takes its first monitoring slice. So what we're seeing here is the 15-second slice, and then every second after, boom. All right, so we get down here, we've got 6 images, so 6 seconds plus the 15. We're at 21 seconds when it triggers, okay? That's our timing. Now, your typical portal venous phase when you scan is like a minute to a minute and 20, minute and 30 seconds, okay? So if we look over here at the abdomen protocol, if I click on this, we see there's a 45-second countdown right there after the trigger, okay? So we were at 21 seconds plus 45, we're at a minute and 6 seconds, right? Something like that. I think that's right. And that's when we scanned this fella's abdomen pelvis. And that puts him in the portal venous phase. We can see that the vasculature of the liver isn't arterial, right? So it's not so early. And then, but we can see the portal vein. If you guys look right here, this is the portal vein. That is also contrast enhanced as that. So that's the portal venous phase, right? We see that enhanced. There is enhancement of the aorta as well. And then we can just kind of scroll through. Look at this tortuous splenic artery, I think that is there. Does that go all the way back to the, let's follow it here. Does it go all the way back to the, yep, right here. This is the splenic artery here coming up, and it's crazy calcified. So that's interesting. So this, anyway, just something I noted on the scan. So then we scan. We scan from above the diaphragm all the way through the bottom. Let's go all the way down, see how far we went. So we didn't go below this patient's testicles, but we can see that we are below the rectum, right here. So yeah, that's the scan. Now on some patients, you will do anywhere from 5 to 10 minute delay. That can be common. In the past, we would, like if I saw something in the liver, there's this common, not pathology, but there's a common representation, something that shows up here on these scans where you have what's called a venous hemangioma. Now, a venous hemangioma looks like a black spot in the liver. Well, so do metastases. They look like black spots. On the 5 to 10 minute delay, those venous hemangiomas will fill in And so that's one way to rule it out, right? But now we just do a standard protocol. If the patient has not had a scan within the last 12 months at our facility, we will also do additional sets of delays, which scan from above the liver only through below the bladder. So we would go through the bladder here. It's the pubic symphysis, the bladder's there. We make sure we're through that, and that would be the sum total of our delays. Again, these protocols, they evolve, okay? And that's just part of the game in CT. Now, this is a good study for you to know, to learn, or just to pay attention to the anatomy. I'm going to cover some quick growth structures for you so you know what you're looking for. Obviously, on the patient's right here, we do have the liver here. This is our inferior vena cava. It's below the heart. I've pointed out here the portal vein, and here's our descending aorta. Scroll back up now, and we can see the stomach here. And it goes down. If we follow it anterior, we will see the pancreas here, the tail wrapped up here by the spleen, moving anteriorly and medially towards the duodenum, where the head of the pancreas sits in the C loop of the duodenum, like right around here, okay? In some cases, you might even be able to follow the pancreatic duct down through, but this patient seems to have kind of a fatty pancreas, which is really common, like if you see a diabetic or even just advanced in age. Young people's pancreas looks very full, and this is like, it's feathery almost. So that's usually a sign of a fatty infiltrate in the pancreas. Here's our spleen, which we pointed out. And then we come down, let's find our adrenal glands. We can see them here, and then another one on the patient's left, right around here, the right above the kidneys, right? Let's see, we have kidneys, both sides, we can see the renal. So if you ever, when you're testing on this, you can see that this comes across this vessel here. It comes across the descending aorta over towards the inferior vena cava. So that's going to be a renal vein. And if we scroll to the artery, we should see it take off here, and that's going to be the renal artery, okay? Now, when you have to do anatomy testing on this, you guys are going to have to be able to look at a single slice and make those determinations, okay? But the more you see them, the easier that gets, all right? So you'll take your time with that. You'll need to be able to identify like the celiac trunk, which is going to have like, let me see, the gastric, splenic, and I think hepatic artery come off of that. Then you go down and you see this one take off here. This is going to be like the superior, or the SMA, superior mesenteric. You'll see it move forward and it'll fork out into this, all these little fibers like that, okay? Because that's feeding a bunch of the bowel. Then there's the inferior mesenteric and all that. So you'll have to know all that. But again, this is just gross anatomy. You can see some transverse colon here. You see it here, it's air-filled. And then you can also see on the topogram over here that it's also air-filled. You can see all the air in that. Anyway, and he's got something nasty going on right here. What is that? Is that his duodenum? Yeah. Look, right here, all of that rattiness and fluid buildup, like this is all fluid. So this may well be pancreatitis. I don't know. I didn't follow the pancreas all the way there, but anyway, it's right there. He's got something nasty going on. That's not a normal appearance of the small intestines at all. And you can see it kind of continues all the way down here. All that fluid buildup that's outside of the bowel, that's not good. And then you can see this patient also has a ton of visceral fat. All this darkness out here is visceral fat. That's probably why his pancreas is infiltrated. Again, we can look too at the descending aorta, here where my mouse is, and watch the bifurcation. Look at all that calcification in his common iliacs there. That's not healthy, right? This guy's in bad shape. We can see fluid-filled loops of bowel and even diverticuli here in the rectum or the sigmoid. So he's just got a lot of issues going on. But that's kind of a quick rundown of his anatomy. We can go down and see one more thing here. Let's look at his prostate. There, doesn't look enlarged. His bladder, the wall doesn't appear to be thickened. Those are just appearances you can see, just things you can look for. Still see the calcification going down there. Yeah, and then the bony pelvis and the anatomy of that we'll get into when we do the musculoskeletal chapters. You guys should be familiar with these muscles here, lateral to the spine. Those are the iliopsoas muscles. You have your erector spinae and whatnot posterior to the spine. Yeah, so you do that. be aware of the anatomy. It's smart to be able, when it does its first scan, to be able to track the anatomy as it goes down. It's super quick, but you'll get to a point where you could just at a glance see what you need to see and know if you need to modify the protocols or catch something different, okay? So just pay attention. Then you typically do coronal reconstructions, at least. Here's our coronal. And then for this one, they also did a sagittal. The sagittals aren't, some facilities do sagittals on everything. Other facilities leave those to specific indications. Like here, we do sagittals for trauma and for appendicitis, so right lower quadrant pain. Everything else really doesn't get sagittals, okay, at my facility. But it varies, and there's no real right or wrong. It's radiologist preference. What can they see on what? I will add a sagittal to a ventral hernia. So if they have a hernia that pokes out anteriorly, sometimes you just see it really well on this particular projection. So I'll do a sagittal reconstruction on ventral hernias. But if we get into what the protocol looks like, this is really straightforward, okay? The protocol on this, let's do the recon tab. We're gonna have 5mm slices with a 5mm increment. B20F smooth is our kernel, and it's just an abdomen window. That's on the sagittal, but it's the same on the axial. 5, 5. Let's see, we use a pitch of 0.7, so there's some overlap there. One thing to note about this particular scanner is it is ACR accredited, so these protocols have already been approved for use, even at a pitch that is that low. You can look at the detectors of it's acquired at 1.2, so we can reconstruct all the way down and do thins. And that's the gist of it. So like I said, this is a really straightforward protocol. It's common. You can, if you don't do delays, one of these procedures may take you 5 minutes. Especially once you get proficient. If you have a transporter at your facility, you could crank these out all day. All right. So again, I said it's like a chest X-ray. So be good at this one. This and a chest CT, you should be able to crank that in the head. There's nothing complicated about it. You may run into complications with more complicated procedures, but these are bread and butter. Okay. All right. I got pretty excited, guys. I found an angio of the abdomen pelvis. So I'm pretty stoked about that. All right, again, we're just gonna run through this like we've run through the rest. I just wanna give you guys some familiarity with this procedure. We do the same topogram as we would on a regular abdomen pelvis. However, then we do our without, all right? So you can see our without, it's just a non-contrast abdomen pelvis. If we look over here, you can already see the boundaries of the aneurysm, right? If we look at the descending aorta, it's normal, normal, normal. It begins to separate, and we can see that there's a lighter color fluid around the true lumen, right? And now that we've acquired this without, when we inject, we'll be able to see and compare the two. That's why it's important that we do the without phase on these, so we can see that, you know. And then you can see it even continues down the bifurcation, which can be dangerous because it's harder to put the mesh on those when you repair them. All right, so we do our without. Now on this one, let's look at this. This is gonna be in a mediastinal window, and it's 3mm. So those are two changes from the previous regular abdomen pelvis, okay? So it's thinner slices, and we use a different kernel and window. B30 and then mediastina as opposed to B20 and the abdominal one, okay? So that's just something to note if you ever had to build this protocol. But if we're talking in terms of basic flow with this, we do our scalp, we do our abdomen pelvis without. Now, then we set up our pre-monitoring slice, which is in the exact same place. We bolus track in the exact same place at the abdomen, but there's a couple differences. All right, let's look at our monitoring. Now, on angiography, our monitor we need to trigger faster than we would on our typical abdomen pelvis, right? We're not in the portovenous phase. We want to be in the arterial phase, which is quick. So if we look here, instead of counting down for 15 seconds, we're only counting down for 10. And we should trigger pretty quick after that, all right? So we count down for 10 seconds, and then notice the delay on the angio. It's only 6 seconds instead of 45, right? So we're trying to come in at 20, 25 seconds for the abdominal aorta, all right? So it's really quick to be in the arterial phase, but look how bright white that is there. All right, couple things to note. In the flow, we do these things. We set up our pre-monitoring. We just want to make sure we don't do our test injection of saline before we do our without scan, because there is about 1 cc of contrast in the when you prime the dual head injector. So you want to be certain that you don't give them any contrast before the without. So what I would do is I'd do my scout, set up all my ranges. The without, I'd set up my width, my angio down here. I put my pre-monitor in the right place, do my pre-monitoring slice, do my test injection, and then I'd start my monitoring. Right, so I hit my injection and my monitoring at the same time, and then it's automated. It's just gonna roll. You know, it's gonna take a picture after 10 seconds. Boom, 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 boom. Break 120, and then we're gonna get this scan. Okay. So we get it. Look how bright that is. Right, that's what we want. That beautiful descending aorta, so that we can see if it's leaking, if it's truly leaking out into this lumen and potentially. Even worse, right? Breaks out and starts just pouring out. People don't live long when that ruptures, right? So we want to be certain that we see that very clearly. Now this is neat to note on the liver. This is what an arterial phase liver would look like. All right, we can see our hepatic artery here branching off our celiac trunk, which is here, comes over, boom. Now look at how the arterial enhancement of the liver, like think of how different that looked in the portal venous flow. Because the portal vein is like right here. Sorry, I got off of there a little bit. The portal vein is right here. And when that enhances, the whole liver gets bright. But look how dark it is here. And all we have is the arterial flow here. Now that's great if we're looking for like hepatic metastasis or primary cancers. But when we want to evaluate all of the parenchyma of the liver, the portal venous phase is better. Okay. Anyway, yeah. So you can just see all these branches, these beautiful branches off of the descending aorta, and it's important that you can look at a CTA like this because it's going to help you study your arterial anatomy of the abdomen pelvis. Anyway, so we scan it through, we make sure that's bright and pretty, and then we do our recons. We're going to do a coronal, and this should be a MIP. So you look here, this is a coronal MIP, whereas on the abdomen it's not. And that should be really pretty. So look at the mesentery. You can see all these branches coming off the superior mesenteric artery here. In some pictures, like if we did thins, you'd see a beautiful web. But you can see the venous web kind of returning blood flow here, but we're in a different phase, right? So look at that aorta. That does not look good. And then we should have, so they did thins here. So we do a coronal MIP, they do thins, and then they export those thins to the 3D card. Oh, don't look. Let me, I'll load that in. Actually, I'll just load it in the viewer so you don't have to watch me cut it out. So this is the, these are the 3D spins they did on that patient. So look how pretty that is. So they load those thin slices into our 3D card over here and cut out all the non-essential anatomy. And then they do this spin, and you can see it all. It's gorgeous. You can even see the calcifications here. There it is. Okay, so that is the angio abdomen for typically indicated by or for the AAA, abdominal aortic aneurysm. Okay, so I tried to make it quick today to kind of go through these. These are really common, so you'll see them more often. But there's a couple things I want you to take away. All right, we did not cover the renal stone. The only difference in the protocol for the renal stone, whereas your regular abdomen pelvis with contrast is 5 millimeters, the renal stone is 3. Smaller structures, thinner slices. Right, that's what we want. Better longitudinal resolution. So. For that's the only real variable there. We may not scan as high depending on the facility. So those are one thing. And then if we look at the angiography or the angiographic study that we just reviewed, make a note of that, because between the abdomen pelvis width and the angio, you really can kind of, if you can do both of those, then you can do any of the tri-phase studies of the liver, kidneys, you know, like looking at the renal arteries, anything like that, pancreas, adrenal glands, because it's just a combination of the two. So for a tri-phase study, you're going to do the without, you're going to do the arterial phase, and then you're going to do a portal venous phase and maybe an additional. So if you can kind of make sense of what we've talked about today, then figuring out a tri-phase is a walk in the park. All right. Again, let me know if you guys have any questions, if anything is unclear, if you want to see anything specific before this semester ends, also reach out and let me know. I'll put together a quick video for you to try to clarify or give you some visual aids in your understanding. Other than that, I appreciate you guys, and I hope to talk to you soon.